Thank you for joining us today for the Solomon Berson Award and lectureship, given to the physician, scientist, or researcher who demonstrates excellence in their field. Dr. Solomon Berson, along with his friend and colleague Dr. Yalow, developed many groundbreaking antigen assays for different disease processes and peptide hormones. Their work included developing assays for type 2 diabetes, parathyroid hormone, ACTH, and growth hormones. Their contributions were later adapted as the base measure for hundreds of additional protocols. Despite their incredible success, neither scientist patented these processes nor profited commercially from their discoveries. Their work in the development of radioimmunoassays as well has been credited as being the precursor to modern nuclear medicine. Dr. Berson later served as the chair for the Department of Medicine here at Mount Sinai, prior to his passing away in 1972. In 1977, Dr. Yalow received the Nobel Prize for their work on the development of these radioimmunoassays. At her request, their laboratory that they shared was designated the Solomon Berson Research Library in order to memorialize their contributions to modern medicine. It gives us great pleasure to present this award to Dr. Juan Wisnivesky, whose accomplishments as a physician-scientist truly exemplifies the qualities that Dr. Berson had demonstrated in his career. Dr. Wisnivesky completed his residency in internal medicine at Montefiore and his fellowship in pulmonary at New York Presbyterian Hospital, Cornell University. Dr. Wisnivesky did additional training and an additional doctorate at Columbia University. As a physician-scientist, he has published several manuscripts using population-based center registries to address screening, diagnosis, treatment disparities in care and outcomes in patients with lung cancer. In his previous role as vice chair for research for the Department of Medicine, Dr. Wisnivesky developed a comprehensive and highly regarded mentoring program for junior research faculty. Dr. Wisnivesky continues to be active as a physician-scientist and mentor, and currently serves as chief of the Division of General Internal Medicine here at Mount Sinai. Please join me in congratulating this year's recipient of the Solomon Berson Award, Dr. Juan Wisnivesky.
Well, thank you very much. I'm really honored speaking in a lecture honoring such a prestige physician scientist, and I want to thank Barbara and David and the chief residents for inviting me to give this presentation. So I'm going to talk about lung cancer screening. What is the evidence supporting this new technique, and also what are the type of information that we still need to translate all these research findings into improved patient outcomes. So these are my conflicts of interest. I'm going to talk first a bit about the evidence supporting screening, then what are the factors that may influence current adoption of screening at the national level, then talk about what are the issues that we need to really be aware when we are implementing screening to ensure that there's equitable access and benefits from it. And finally, talk a bit about lung cancer treatment, given that treatment is the ultimate stage to so that patients can benefit from screening. So why screening is important? Lung cancer, as you probably know, is the second most common cancer in the United States, and the most common cause of cancer mortality, accounting for approximately a quarter of all cancer deaths. And also, as you probably know, the main risk factor for lung cancer is smoking. Here showing rates of tobacco consumption in the population, and lagging 10 to 15 years later, the incidence in mortality of lung cancer both in men and women. But you are hardcore scientists, as Dr. Berson, and you want hard evidence for the association. Here you clearly have the lung cancer and the cigarettes in the same picture. So everybody knows about the NLST and the publication of the results for lung cancer screening, but actually this work started many years early with the seminal work of Dr. Henschke, which is sitting here and works at Mount Sinai. He was my first mentor, who published a result, an observational study of lung cancer screening, a cohort of 1,000 smokers, and showed not only that smoking is feasible, but that 85% of lung cancers diagnosed with screening are early stage, stark contrast what, more than half of the cases that are advanced stage in the clinical practice. 10 years later, the NLST was published. This was a large randomized controlled trial of over 53,000 patients, smokers, 55 to 74 years with 30-pack years of smoking. And the participants underwent 3 rounds of low-dose CT versus chest X-ray. As you can see, lung cancer incidence was higher in the CT arm compared to the chest X-ray arm. But more importantly, lung cancer mortality was significantly lower among those who underwent low-dose CT. This translated in approximately 20% reduction in lung cancer mortality and a 7% reduction in all-cause mortality, with the number needed to screen to avoid one lung cancer death being 308. So the results of the NLST are important and highly internally valid, but they may not be generalizable to some special populations. So in our group, we're interested in understanding and studying how lung cancer screening may apply to these groups. One of these groups are patients with HIV. Patients with HIV have higher risk of lung cancer, both from increased rates of smoking, but also because of HIV itself, but also there's data showing that they may have also cancers, may have higher aggressiveness, which are 2 factors that may suggest screening would be more beneficial. Conversely, there was concerns that lung cancer may find more false positives in patients with HIV, given the prior history of lung disease, as well as clearly patients with HIV have lower life expectancy from competing causes of death, and that may attenuate the benefit of screening. So in order to solve these issues, we conducted research using a sophisticated simulation model, which is the lung cancer policy model. And in using this data, we first, in collaboration with a group as Mass General, first showed that, the model clearly replicated the NLST results with approximately 20% reduction in lung cancer mortality, and that patients with HIV, with well-controlled disease, could also benefit in a similar fashion, with approximately 18% mortality reduction. Moreover, we also evaluated different screening regimens because HIV patients get lung cancer at a lower smoking exposure and a younger age. And while the current recommendations were beneficial, we show that screening regimens that started at an earlier age could translate into a higher overall improvement in survival. Another group that may also potentially benefit from screening is patients with COPD. Also, patients with COPD are different from NLST. First, they have increased risk of lung cancer, which has been quite shown in the literature, but also may have higher risk of harms from screening, including more complications from the diagnostic workup, increased perioperative mortality, and also decreased life expectancy from COPD. So Minal, which is a faculty at our division as part of IK, she developed another simulation model to look at screening in patients with COPD. And she found that, compared to patients in LST, lung cancer screening could also lead to significant reductions in lung cancer mortality of around 20 to 30%, so even potentially higher than in the general population. After the results of the LST, there has been a lot of interest in optimizing eligibility criteria so that the best patients can be selected for screening and get the maximal benefit. One strategy that has been commonly used is try to use prediction models to assess individual patients' risk of lung cancer and select candidates based on these criteria. In this study published in the New England Journal of Medicine, investigators did exactly that with NLST participants. And they estimated each person's risk of lung cancer and then divided patients in 5 quintiles from those with the highest risk to those with the lowest risk. And what they show is that if you screen the 3 higher risk quintiles, you can prevent almost 90% of the deaths that you prevent with screening, with the other 2 only accounted for around 10%. Similarly, that's reflected in the number needed to screen, that it goes from only 160 to prevent 1 death among those at the higher risk to 300 in the higher cohort, suggesting that potentially you can reduce the number of screening in the population with still achieving a lot of the benefit. We were also interested in assessing what of the information on the first CT could tell you about the future risk of lung cancer and how that can be used to optimize additional rounds of screening. So in this study, we also used the NLST data, and we focused on the patients who underwent CT, and furthermore on those who have 2 negative CTs, which will require further rounds of screening. So we use the same models I described before to estimate patients' risk of lung cancer, and then stratify the sample into quartiles based on lung cancer risk to assess the additional contribution of emphysema. What we show is that, for example, here in the dashed red is the cumulative number of cancers in NLST among patients who had a higher risk of lung cancer and did not have emphysema. And this was significantly lower to the same group with emphysema. And this was true across the 4 quartiles. Again, suggesting that absence of emphysema could be a criteria to determine further screening. And this is reflected in the number needed to screen to detect 1 lung cancer. While for the whole cohort was 166 CTs to detect 1 cancer, and this went up after 2 negative CTs to 227, there was a huge difference among patients with or without emphysema. Those without emphysema, you need to screen 367 patients to detect 1 lung cancer, and this dropped to only 86 among those with emphysema. Again, this information could be used to target, optimize further rounds of screening among those who have negative baseline CTs. Another interesting finding on baseline CT is the presence of absence of interstitial lung disease. It's well known that several interstitial lung diseases, such as asbestosis or IPF, are associated with increased risk of lung cancer. However, less is known about what is called interstitial lung abnormalities, milder findings among asymptomatic patients. So Stacy Brown, which was a former fellow now starting as a faculty in pulmonary, used also NLST data, and she looked at baseline CTs and compared those who had versus did not have interstitial abnormalities, and showed that the cumulative risk of cancer was significantly higher among those with ILAs. Moreover, in adjusting analysis, she showed that the risk of lung cancer was approximately between 50 and 60% higher among those who have ILAs on baseline CT, suggesting that this may be a new independent risk factor for lung cancer, which also can help, further optimize, additional rounds of screening. So the evidence is pretty strong. How are we doing in terms of adoption of this new potentially life-saving strategy? Well, unfortunately, not that great. This is a population-based study from the National Health Interview Survey, which a weighted sample of approximately 70 million U.S. Patients from the population, and it showed that only between 4 and 5% of high-risk smokers are currently screened for lung cancer. Even more worrisome, approximately 1 to 2% of never smokers, which never been screened, are receiving screening. So that's pretty dismal. So what are the factors? What potential issues may be a barrier to adopting screening? Well, one is concern about false positives. As shown in these slides, and across many studies, approximately 20 to 30% of baseline CT will find non-calcified nodules. And most of these patients do not have cancer. So these generate a long list of tests that could be done to work up these patients. While most of these patients can be worked up non-invasively and with imaging, and also data consistently show that very few need unnecessary biopsies or resection. This is a concern for both patients and physicians. And not only that, remember, primary cares are ordering these tests and then have to deal with the results. And as you see, the guidelines for working these nodules are not, light. And you learn the NCCA guidelines, and then maybe you need the Lang-Rats, and if not, the Fleischner criteria, and maybe the ILCAP criteria. There's a lot of agreement, but can you see how primary care doctors can be a bit overwhelmed by these guidelines? And I just want to clarify that many screening programs, such as the one here, will do this work for you and handle the management of these nodules. However, remember also that most of the care in the United States is provided in the community and not in advanced tertiary care centers. So this could be a significant barrier. So machine learning may help in this issue, and there's been a lot of research to try to use artificial intelligence to try to further stratify these lesions and automatically identify those who need additional tests. And this study, recently published in Nature, investigators use deep learning, which is a type of machine learning approach, to try to differentiate between solid, semi-solid, part-solid, and calcified screen-detected nodules. And the investigators show that the computer-based algorithm had pretty good agreement, and it was almost as good as expert radiologists, suggesting that maybe these automatic approaches in the future may help managing these nodules. Or maybe not. So an alternative approach is to use biomarkers to try to further identify patients who need nodules that need further workup. And this research, which is a collaboration between Charles Powell here also at Mount Sinai and a group in China, they use a mixture of clinical factors and blood biomarkers to try to identify which nodules may be malignant and need further workup. And they show in the derivation cohort that this combination of biomarkers have a high accuracy, approximately 92% accuracy in identifying nodules that were malignant, and that was better than the current CHEST guidelines to identify malignant cancer nodules. However, unfortunately, something that commonly happens in studies, in the validation setting, these results were not as strong. Another concern about lung cancer screening is overdiagnosis. And by that we mean screen-detected cancers that are considered malignant, but that either never progress or they are so slowly that will never be clinically detected or cause a patient death. And this is considered potential harm in screening because these patients will undergo resection but really do not benefit from that treatment. However, the extent of overdiagnosis is unclear. So it's interesting that you can learn about overdiagnosis from actually untreated lung cancer patients. Because if you think about it, if you simulate here, as we do here, a group of untreated patients with lung cancer, and you look at lung cancer-specific survival, basically you take away death from other diseases. Then, if a group of these patients is the curve plateau, meaning that up to a certain point, these untreated lung cancer patients do not die from disease progression, this is actually the definition of overdiagnosis. Cases that are untreated but are not progressive. So you can use the point where the curve plateau as an estimate of overdiagnosis. So in a study with Minal and Keith, also from the division, we look at CR Medicare, a large national registry, and study over 2,000 patients with untreated stage 1 lung cancer. And we show that both among men and women, overdiagnosis was uncommon, around only 2%. However, that changed significantly with size, where for smaller tumors less than 15 millimeters, approximately 10% of the cases could be overdiagnosed, and for tumors that are larger, over 4.5 centimeters, rates of overdiagnosis were 0. Radiation is another issue related to screening. Again, you're going to put patients, a smoker, through at least 3, but maybe 10 to 20 years of screening. And here it shows the exposure of a CT, which is approximately equivalent to 14 chest X-rays or 3 mammograms, and then half of a third of the yearly exposure in the U.S. However, data from a large screening cohort from Italy show that the attribute the number of cancer cases to radiation exposures, even after 10 years of screening, is pretty low, less than 0.05%, suggesting that this is not a major concern. What about the primary care providers? As I said, primary care doctors are the one implementing and requesting the screening. So Dr. Ling, which is also a faculty here, conducted a study at Sinai where she asked primary care doctors about their attitudes and beliefs about screening. As you can see here, most providers, almost 99% of them, felt familiar with guidelines for breast, colorectal, or cervical cancer screening. However, only half of the providers, were, knowledgeable of lung cancer screening guidelines. Moreover, several providers have attitudes that were less favorable about lung cancer screening, including only 14% feeling that they have, sufficient time to counsel their patients about screening, or 90% of them feeling, worry about, false positives and the workup of those. And this is important because there's an additional burden to primary care doctors, which is that current CMS recommendations mandate that, before screening is ordered, providers or some other, nurse as part of a screening program does a shared decision-making session using an official decision aid. And while obviously shared decision-making, it is something that is beneficial for both smokers in terms of making the decisions, this adds additional time and burden for screening and is not required for any other screening test. To further complicate things, this shows you a list of Medicare mandated core measures for primary care doctors. This is what Medicare tells our primary care doctors they should do for their patients and are held accountable for. As you can see, several cancer screening strategies are mandated. However, lung cancer screening is missing from this. Therefore, primary care doctors are not held accountable for how much screening for lung cancer they do. So those are some of the barriers, but how do we implement screening, adopt screening, so that everybody equally benefits from them? Well, unfortunately, the burden of lung cancer in the United States affects more significantly minorities, particularly blacks. And while the NLST was a large study and highly generalizable, the number of African Americans and Hispanic patients are underrepresented compared to the general population, which is a common theme in many studies. And this is important because there is data that show that blacks are maybe more susceptible to the effects of smoking than other populations, particularly whites. In this large study from California, it shows higher incidence for both men and women which were black. And while this is self-reported race and a social construct and may not reflect actually true biological differences, could be related to smoking patterns, the type of cigarette smoke, this is still important because current guidelines for screening do not take into account the susceptibility by race, and therefore may leave many black patients who are at high risk of lung cancer non-eligible for screening. Moreover, it should be noticed that Medicaid does not cover screening, and therefore, and because many minorities are low socioeconomic status, they do not have good access to screening tests. Additionally, we conducted a study several years ago showing that there are differences in the beliefs about screening and lung cancer among different racial and ethnic groups. And Black and Hispanic patients have very different perceptions about the risk of lung cancer, fatalism, attitudes toward cancer, as well as increased worries about the potential side effects of screening. Obviously, all of these need to be taken into consideration in discussion about lung cancer screening with minority patients. Finally, as I mentioned before, and I will discuss in the second half of the lecture, for screening to be beneficial, there should be optimal treatment. And this is data which has been clearly shown in many studies that black patients in the United States with early-stage lung cancer have worse outcomes, and this is explained by lower rates of resection. So another barrier for minorities to benefit from screening. So this is a lot of evidence that, things are maybe different for minorities in terms of screening. I think, we may want to implement screening in a different way. The typical approach for new interventions, for screening tests, is that we roll them out, and then 10, 15 years later, we look and study where disparities are, surprisingly with findings. So I think maybe with screening, lung cancer screening, we need to reverse things and really consider all these issues that I mentioned, and included in the adoption of screening, so that when screening is rolled out, minorities really have same rates and equally benefit from this potentially life-saving test. So what about treatment? How we can make sure that early diagnosis, which is the stage shift introduced by screening, translate into improved survival. Well, unfortunately, there's a lot of gaps in terms of the knowledge we have about the optimal treatment of early-stage lung cancer. First, prior to screening, less than 20% of lung cancer were early stage. Therefore, this was not a major focus of research. Second, lung cancer screening, as I said, detects smaller cases and some that may have less aggressiveness. So the approaches that were used for clinically detecting cancers may not fully apply to this population. So therefore, all these factors create gaps in knowledge. So what is the standard management of early-stage lung cancer? Well, surgery is a preferred approach, mostly lobectomy, but there is data suggesting that I will share with you that limited resection may have a role for some patients. Patients for stage 1 are followed with observation. However, patients with stage 1 disease, which have positive pulmonary hilar nodes, are recommended adjuvant chemotherapy. Approximately 20% of patients with early-stage lung cancer are either unresectable or have preference against resections, and those usually treated with SBRT, and for tumors more than 5 centimeters, they usually receive standard radiation. So what is the evidence supporting these treatments? Well, this is it. There's been very few randomized controlled trials. There are some old trials which I share with you for surgery from RT, but conducted over 50 years ago. And there is a single trial in the mid-80s compared limited resection with full resection for lung cancer. The rest of the therapies are completely unstudied. And this is a stark contrast with other oncological procedures, particularly chemotherapy. As you probably know, immunotherapy has been recently adopted for advanced stage lung cancer, and this is a number of studies that have been recently completed evaluating the potential effectiveness of immunotherapy, and the list probably is incomplete and growing, and this is the list of ongoing studies. Clearly a huge difference compared with interventions for lung cancers that are rapidly adopted without much evidence. So, as I say, surgery is considered the standard of care. Nobody, if you go to a tumor board, nobody will doubt that a patient with early-stage lung cancer should be resected. However, if you look at the evidence supporting surgery, is less, clear. These, as I said, were studies conducted many, many years ago comparing surgery to radiation therapy, types of radiation therapy that had been long abandoned and that were very, very simple. And as you can see, the risk of death following radiation therapy was higher compared to surgery. However, all the confidence intervals include one suggesting that surgery was not better than these really simple, now considered useless forms of radiation. So maybe we don't should use surgery. Well, this takes you to this very interesting study that was published in the BMJ a few years ago, looking at the evidence for using parachutes to prevent death once you jump from an airplane. And actually, the investigators really, and this is a true paper, it was published, it's very funny, really did a systematic review and could find no randomized trials. And then they concluded that maybe the basis for the effectiveness of using parachutes is actually due to a healthy core effect. Maybe these patients also smoke less, have a better diet and exercise, no? And, it's all bias, Well, this is kind of very nicely written paper, but it kind of goes to the point that unfortunately in medicine there's many things that we cannot base our practice on randomized trials. And what randomized trials provide the best level of evidence, many times we need to make decisions based on other type of data. So how do we use this data for early stage lung cancer? Well, first, as I mentioned before, there are different types of surgeries that you can do. The standard of care is lobectomy, which is the resection of a full lobe. However, alternative approaches include segmentectomy, which is the resection of an anatomical segment, or wedge resection, which is resection of the tumor with a small sleeve of parenchyma around it. Lobectomy is a preferred approach. However, this is based on a single RCT, more than 30 years old now, and that provided actually mixed results with not really clear advantage of full resection. As I say, this may be too much of a resection for small screen-detected tumors that may be less aggressive. So we were interested in addressing this issue with observational data, given the lack of randomized trials. And in this study, we used SEER, which is a large national cancer registry, to evaluate patients with stage 1 lung cancer less than 2 centimeters, the typical size of screen-detected cancers, and we compared those who underwent limited resection with those who underwent lobectomy. The challenge with this, SEER, as I said, which we use this registry linked to Medicare claims, is a national registry that includes all new cases of cancer in several states as well as metropolitan area and represents approximately a quarter of the US population. So the problem is that when you do these types of observation study, as you have bias. The patients that receive one treatment may not be comparable to the others. So bias. I hope you get the point. Didn't fit anymore in the slide. Is a huge issue. So how can you address this issue? Well, before that, I think the best example of bias, this type of selection bias, comes actually from history. And this is a true story. During World War II, the British will send planes to Germany, and up to a third of the planes were not returned. And there was a huge problem, particularly because they were losing a lot of the pilots. So the RFA conducted a survey of the planes returning to try to identify where were the areas that received more bullets, so in order to apply reinforcement plates in those areas to have less planes shut down. And then they did a map like this, and I copied this from Wikipedia, that is the best source of knowledge, even better than the New England Journal, and have something like that. So if you were doing this survey, would you put plates in part A, part B, or part C? Who'll say part A? Raise your hand. One person there. Few? More? Okay. Sorry. Oops. What about B? C? A lot. Why C? Anybody? Yeah. These are the planes. They were sampling the planes that came back. Those areas that received no bullets indicating that all those planes were still back in Germany because they were shut down, okay? And here, clearly the issue of selection bias completely turned your data around, and if you don't include that, you'd make the wrong association. Actually, the RFA wanted to put the plates in the areas that received more bullets, and there was a very, sophisticated mathematical unit that had a major role in the war that told them, no, guys, you're thinking this all wrong. And then they actually put the plates on the areas that had less bullets, and it significantly dropped the number of planes that were dropped in Germany. But this tells you the power of selection bias. And if you don't properly consider, your results can be completely biased. So let me just get a small technical explanation here. But you can really skip the next slide, without loss of continuity. So this is time to use your sleeping tie if you were, smart enough to get one, and deploy it. So how do we try to address, selection bias with observational data? Well, a randomized controlled trial is easy. You have a group of patients with stage 1 lung cancer, and they are randomized with equal chance to get lobectomy with limited resection. And then, obviously, the two populations are well balanced, and then you can compare in terms of survival. In an observational study, you start backwards. You have patients, and some got lobectomy, and some got limited resection. So what you need to do is first build a statistical model that predicts type of surgery. For example, lobectomy. From the data, based on patient characteristics at the time of presentations, age, comorbidity, etc., etc., etc. Then you take your population, and using this model, for each patient in your groups, you estimate the specific patient probability of getting lobectomy. If you're lucky and you have enough large sample, you have something like this, where among patients treated with lobectomy, you have a group of maybe younger, healthy individuals that have a higher probability of getting lobectomy, but also some patients that may be older, have more comorbidities, poor functional status, but still got more aggressive surgery, and the same thing for limited resection. So what you can do then is sample from each group 2 patients with the same probability of resection based on the characteristic at the time of treatment. And then you keep doing that until you have 2 groups that are well balanced, and therefore you can do meaningful comparisons of survival. So this is what we did with these 2,000 patients in SEER, and what we found is that when you look at the risk of overall mortality, patients with limited resection have approximately 10% increase in overall mortality, but that was not statistically significant, suggesting that the 2 treatments may be equivalent in this population. However, when you look at bigger tumors, when you go up to 3 centimeters, limited resection did worse than lobectomy, suggesting that a more aggressive approach is needed. As I mentioned before, another evolving treatment for early-stage lung cancer is SBRT. And this is, the CyberKnife, which is used for brain tumors, which provides a lot of radiation focused to a small size where the tumor is, therefore, potentially eradicating the disease. And this was first introduced, approximately 10 years ago with this publication of this phase 2 study with treated unresected early-stage cancer patients with SBRT, and showed rates of survival that was considerably higher than those observed in historical controls treated with standard radiation. And this follows as in any new technique in the United States, particularly if it's potentially more expensive, with a quick uptake, and you see how SBRT quickly replaced other types of therapies for early-stage lung cancer, despite the lack of randomized trials. Actually, 3 RCTs were started approximately 10 years ago, and they all were stopped because they failed to recruit. There's new ones that are going, but I think they're still also having quite significant challenges. So, using this approach that I mentioned before, using populational data to try to fill gaps in knowledge, we conducted this study with Nicole Esser, which was a fellow from Canada that now is at McGill, and we used SEER data over 2,000 patients to look at survival of those who underwent SBRT versus limited resection. And as you can see in the overall cohort, there was increased risk of death among those who underwent SBRT. However, that was not statistically significant. However, SBRT fared worse than segmentectomy, which is the resection of entire segment of the lung. So in a patient which may not be a candidate for full lobectomy but could undergo segmentectomy, this probably should be the preferred approach. Finally, the other potential treatment for early-stage lung cancer is standard RT. This is data from a study we did, over 15 years ago, which was the first study to compare side-by-side, patients treated with standard radiation versus no radiotherapy, and this is a standard of care for unresected patients more than 5 centimeters. In this study, we showed that radiation therapy was associated with approximately 6 to 7 a month gain in life expectancy, and then we use, again, propensity score approaches, and we showed that that would translate in approximately 20% reduction in lung cancer mortality. However, what about unmeasured confounders? And this student physician is like thinking maybe this patient may not do as well, with radiation therapy. And, what he's seeing, his gestalt may sometimes be hard to measure in a database with variables. So, can you really account for that with observational data? Well, there is a method called instrumental variable analysis, which is a technique that can simulate an RCT using observational data and allows to control, seems magic, but controls for both measured and unmeasured confounders, and has been used for many health-related questions, and it provides the best level of evidence for observational data, not quite as high as RCTs, but the next best standard. So, while I'm skipping all the technical details, and I have a couple of slides that you can certainly use if you have trouble sleeping at night, we did apply this technique to the SEER Medicare data, and we found that, compared to those who, this will be the standard approach. If you use the standard approach and you compare 1 year survival, you will estimate that radiation therapy improves survival approximately 14%. And this, however, includes the potential bias of unmeasured confounders. However, when we apply the instrumental variable approach using geographic area as an instrument, we estimated that radiation therapy it was associated with a 10% improvement in 1-year survival among unresected patients, and this again adjusting for all types of confounders. Finally, as you may know, immunotherapy has been increasingly used for particularly advanced stage lung cancer, and it's now the standard of care for advanced tumors. And this recently published study evaluated the feasibility and safety of immunotherapy as neoadjuvant therapy for early stage lung cancer before resection. And they show that if you look at percent regression, which 90% is the threshold for a significant response, approximately 50% of early stage lung cancer that got immunotherapy did show a response, suggesting a potential future role, particularly for among high-risk patients that may recur after resection. So finally, we're doing research, again with Keith, where we are trying to evaluate what is the optimal management of early stage lung cancer patients with comorbidities, another group that are typically excluded from randomized controlled trials. And for this, we're using the lung cancer policy model, which is a very sophisticated simulation model, which actually has been used to come up with the United States Preventive Services Task Force recommendation for lung cancer screening, and which includes 40 computer modules. And this is a basic structure, but if you blow up in any of these, you will find something like this, which a lot of pathways that are all simulated and has been very well calibrated to existing cohorts. So we're using this model to assess the treatment on patients with comorbidity, and for example here we have a stage 1 patient with coronary artery disease and showing survival over time based on treatment with lobectomy, limited resection, or SBRT. And if this is for a patient with good performance status, which shows that both survival and quality adjusted survival and the rates of complications with each treatment. However, the model may show that for a patient with poor performance status, limited resection actually provides better outcome and less toxicity. So this is a way to explore and replicate randomized controlled trials on groups that could never be randomized. So in summary, I think there's strong evidence supporting the benefit screening. This is equivalent to other cancers for which we do have established screening programs, and that higher adoption of lung cancer screening hopefully will translate into increased survival of high-risk smokers. Second, I think screening criteria could be individualized based on additional risk beyond those who are currently included based on smoking and age criteria, and potentially updated based on findings on baseline CT to kind of really optimize the best screening regimen for further rounds of screening. Also, I strongly feel that the issues that I mentioned about race should be taken into account when screening is implemented in the United States, so that we take a preventive approach and we avoid disparities in screening and outcomes in the future. And I think there is a lot of need to better understand what is the best optimal management of these patients, screen-detected patients, to maximize survival outcomes. So this is a bit of a timeline of the different, the history of lung cancer in the United States, from the 1960s, the 1970s when the first cases were recognized, to what I review now. And Dr. Solomon, as we say, which we dedicate this lecture to, was born in 1918 at the height, at that time, where lung cancer was almost an unknown disease. There is a report from a surgeon, from one of the busiest surgeons from 1900 in 1908, where he wrote, when he did his first anatomy pathology of a patient with lung cancer, his mentor told him that he should pay attention because we'll most likely not see another case in the rest of his life. So that's where he was born, and then unfortunately he died in 1972, where we were at the peak of the lung cancer epidemic, and the only potential screening test at that time was chest X-ray, which was shown to be not effective, and the cases and there were very few effective treatments. So I dare to say that he may be excited about all the recent discoveries and maybe hopeful that with low-dose CT screening and new mechanistic-based targeted therapies, we can really improve the outcomes of lung cancer patients in the future. So these are my acknowledgement. Obviously, this is a huge team that participated in all these studies, and this is kind of the fun of doing this type of research. And obviously thank our funders. And I guess that's all. I'll be happy to take any questions. Either that was very clear or they didn't understand what I said. I forgot to read the captionings, but
I want to thank Juan for a fantastic lecture, and I also want to thank Juan for everything he's done for the department in his role as division chief, and also in his role as a mentor, not only as the vice chair for research, but as his role as a mentor for his own lab and for his own division. He really is exemplary in what he does, so thank you very, very much.
Thank you.